Thank you.
Yeah.
I'm Barbara Boucher. Okay, good. Is that all right? You can see it? Okay. Well, I'm Barbara Boucher. I'm talking to you from southern England. I'm attached to my old patch in East London. And my topic today is whether vitamin D deficiency may contribute to the increased severity of COVID illness that we are seeing in this country from COVID-19. The risk factors for COVID-19 you'll all be well aware of, I fear. Chronic ill health, being older or male, being obese, having diabetes or other chronic disorders, increased risks, as do adverse features of lifestyle, sort of inactivity, smoking, poor working conditions, and lower socioeconomic status that I won't go into further, as well as environmental factors that one can't do much about, which include low UVB, which of course kills microbes directly. So I'm not claiming that much for vitamin D, but I would like to suggest that it's one of the factors promoting immune protection. And we don't have an awful lot of protective factors, because apart from that, we're talking vaccines, shielding, lockdown, and distancing, which is a depressing story. Now, in Britain, we have increased COVID prevalence in people with dark skin here in Britain. For example, in NHS workforce, 21% of it, the time of the study I'm just mentioning, was Black, Asian, or minority ethnic, BAME for short. But the death rate amongst them was 63% of the deaths amongst that healthcare group, as published this year, which is a very depressing figure. However, by the time of the second wave, the rates had fallen somewhat in most dark-skinned groups, but had risen in Pakistani and Bangladeshi origined people. Now, one example just recently published of survival up to day 30 in groups of different ethnicity. If you look from day 0 to day 30, survival from COVID with white skin was the best. With brown skin in South Asians was the worst, and for the Black people in our community, it was somewhere in between. Vitamin D deficiency is known to be more common and more severe in such communities. Not only does the melanin act as a sunscreen, but there's an element of sun avoidance for various reasons, and women often use cover-up clothing for cultural reasons, and indoor work styles are pretty common. Diet still tends to be somewhat different in these communities. For example, South Asians prefer ghee, clarified butter, and don't eat fortified margarine. They're very fond too of imported fish and not very fond of British fish, but the D content of such fish is highest in two of them, koi, which is horribly expensive, and hilsha, which is dangerously bony. While if you buy farmed fish, say in supermarkets, which is cheaper, it is notoriously low in vitamin D because they're not fed the stuff. So the real question is, could preventing deficiency of D reduce the severity of COVID illness? Are there relevant mechanisms? Yes, I think there are. Vitamin D is well known to promote increases in innate immune responses. Those are things that kill microbes, either by increasing defensins or cathelicidin secretion. In addition, it promotes and then modulates acquired immune defenses, which should help reduce the risk of cytokine storms. For example, it's known to increase the secretion of anti-inflammatory and reduce the secretion of pro-inflammatory cytokines. Furthermore, vitamin D is protective against the damaging effects of acute respiratory distress syndrome on the lung, certainly experimentally, by increasing the secretion of ACE2 receptors specifically in the lungs. Now, in Britain, I can only really talk about Britain. Vitamin D deficiency problems are not terribly well known, or certainly haven't been. And we've had what I consider inadequate public health advice and no very active measures for about 50 years. For example, when South Asian immigrants began to come here 50 years ago, rickets was a problem and remained a problem from them virtually till now. And when reviewed by a respected historian, she wrote that diet became a proxy or shorthand for a mixture of culture, religion, and race, while the disease, i.e. rickets, justified a pressure to assimilate. And I don't think that's a good approach to solving a simple nutritional problem in a whole community, because in effect, this has allowed persistence of severe deficiency in our dark-skinned communities as a continuing racial inequality. And I'm afraid I would call a brick and say it's discriminatory. Furthermore, talking of the disorders that increase the risks, diabetes is 4 times as common in most BAME groups than in other Britons, and obesity twice as common. And we also know that obesity, diabetes, and severe illness reduced hepatic 25-hydroxylase activity, thereby reducing your concentrations of serum 25D. Now, target tissues, I don't mean the kidney, I mean all your immune cells and other cells that respond to vitamin D, they activate 25D, forming calcifidar in situ. They have the same hydroxylase as the kidneys for doing this job. And the amount they produce increases in parallel with higher 25D concentrations. So the reduction in 25D induced by obesity and diabetes, and probably also by severe illness, creates vicious circles that worsen the effects of deficiency on the tissues. And the idea of dismissing associations and studies as simply reflecting reverse confounding is one that I think has to be challenged. So those disorders, if that's true, should increase the requirements for this vitamin. In obesity, if you're overweight, you need at least 1.5 times as high a dose. And if you're obese, you need 2 to 3 times a higher dose of D3 to reach the same target 25D as do those of normal weight. So obesity does increase your requirements. For diabetes risks, as another example with which I'm particularly familiar, this follows on from what can be decades of increased insulin resistance and becomes overt when insulin secretion begins to fail. Now, vitamin D is known to be essential for beta cell insulin release and secretion. That's been known since the 1980s. Furthermore, calcifidar promotes functions in the liver particularly, and also probably in skeletal muscle, that are protective of insulin sensitivity. Now, those facts should translate into type 2 diabetes risk reduction with repletion. I've held this view since 1998 when I first wrote about it. But many trials set up in good faith have failed to reduce such risks with supplementation. That might mean there are no benefits, or it might simply reflect poor trial design or data analysis. Now, I'll just pick one example, and such examples are popping up in the vitamin D field across many areas. The D2D trial overall analysis showed no risk reduction for type 2 on up to 4,000 units a day. However, following the noise that many of us have been creating about how such trials should be analyzed, the data was reanalyzed after stratification by achieved vitamin D status. And it was shown that the risk reduction for type 2 increased up to at least 70% when intra-trial 25D values were achieved through the trial of at least 100 nanomoles per litre. Bear in mind, in Britain, our definition of adequacy is 25 nanomoles, and in most countries in the world, it's 30 or 50. But people only got to that level on 4,000 units a day, and even 3,200 daily doses didn't do the job. So while 400 units a day is thought to maintain bone health, in dysglycemia, you need 10 times as much. So that for raised glycemia, both your effect threshold here, 100, not 25 nanomolar, and your intake needs are increased. So that explains an awful lot about trial data. Now, D3 has been used to treat COVID, often in high doses, and when that failed, even higher doses have been given, and mostly they have been found to be unhelpful, including the latest rather small trial reported in JAMA this month. But bolus doses have an adverse effect. Do the people giving them know about these? It's been thought to stimulate self-regulation in order to avoid becoming toxic and hypercalcemic, because over many months after huge bolus doses, you have increased risks of falls and fragility fractures. This is now explained because bolus doses have two protective effects. They upregulate the formation of catabolic 25-hydroxylase that inactivates both 25D and calcifidar in the tissues. And it upregulates the secretion of fibroblast growth factor 23, which is known to inactivate the hydroxylase that activates 25D to form calcifidar. Furthermore, if you look in the tissues after you've given a bolus dose, here was 200,000 units, and you look with time, it goes up, sure, but it doesn't come down very quickly. It's still raised at 3 months. So you are likely to be controlling, regulating cell calcifidar content for at least 3 months, which must explain a lot of the failures. And it also explains why increasingly with recent trials, small, daily, regular doses have been shown to be better than any interval doses. And these findings create a nasty thought in my mind that those people with COVID who survive having had these big bolus doses may develop D deficiency defects later on. And I hope it won't prove to add to the problems of long COVID. Now, vitamin D, because of the effects I've mentioned, should be protective against respiratory infections. For upper respiratory tract problems, trials with daily supplements in deficiency, but not using interval bolus dosing, in meta-analyses of between 20 and 45 different trials, have shown significant reductions between 25 to 70% on 400 to 1,000 international units a day, but not with boluses, remark. Similarly, exacerbations of CPD are reduced by daily dosing in the same way. And while you would expect big benefits for pulmonary TB from old data on the benefits of sunshine for treating it, and indeed cod liver oil dating back to the 1800s, we are still lacking in definitive data. Deficiency is known to predict increased risk of reactivating latent TB, and supplementation increases your rate of sputum conversion in multi-resistant TB. Other effects remain to be further studied because most of them have used interval dosing to improve compliance. And I'm afraid a lot of that work may therefore need to be redone in some way. For COVID-19, as I've said, the effects are dubious, but it's mostly been bolus doses. Not only do they induce self-regulation, but the rises in 25D are quite slow. And the rises in intracellular calcifidar, therefore, also slow. Furthermore, another reason for the drop in 25D concentrations in illness is that the liver produces less D-binding proteins, thereby increasing free 25D availability. And I was interested in the talk that covered this area earlier. So it immediately creates the thought, why on earth not use 25-hydroxy-D in treatment, because calcifidar, which that is now available as medication. It should do better. It raises 25D levels much faster than giving intact D3. The slow-release formulation doesn't induce those self-regulatory effects. And, of course, it bypasses the adverse effects of obesity, diabetes, and illness on the liver 25-hydroxylase. And we already know that lower 25Ds at admission with COVID predict increased severity of illness with increased need to go to intensive care and increased death rates. One pilot study is out after peer review from Cordoba in Spain. Doses of calcifidar were given regularly, and the odds ratio for the need for intensive care was virtually nil, well, 0.03, ludicrous, almost impossible to believe. And there were no deaths amongst the small numbers that were transferred to ICU. Well, no one would accept such low figures. So in Barcelona, they've done a similar trial. Couldn't be a randomized trial. You imagine in the middle of a pandemic, can't do that. But they took whole wards and did a cluster trial. Wards were either given calcifidar, all of the patients, or none of them. And to sum up the findings, here you see controls and treated, that the 30-day admission rate to ICU was hugely reduced, and that the mortality rates here in the black compared with the grey were also hugely reduced. Now that came out, it was submitted to the Lancet, and a preprint was issued. Then people were very interested to look at that. But the Lancet then withdrew it, saying that scientists, unnamed, had said that a health warning was needed on this preprint. Now, I can only imagine that this is because perhaps the statistics used had not been specific to cluster analysis, and one hopes this paper will re-emerge in due course. What did emerge a week or so back in the BMJ was an editorial by 3 respected workers saying that for vitamin D for COVID, benefits were possible, evidence was sparse, and trials are justified. I have to say that annoys the 200 or so people who've contributed to open letters trying to get action in these areas, because in Parliament it was stated that the government had got trials on the go, and that had to be corrected. It was not true. There is one trial using 3 different doses in the community, organised and led by Martin, that is in progress and nearing completion, and the results will be, I hope, important and not totally wrecked by the vaccination programme. He had to raise the money for that, not from grants, but from charities, etc. So, importantly, if a better D status protects you from COVID severity, then surely having a better status before the pandemic hits you should also be protective. There are 2 results to mention. In the UK Biobank data, Ma et al. Have reported that after adjusting for all the covariates, the habitual use of a vitamin D supplement, no other supplement, not a mixed vitamin one, just a D supplement, did reduce the risk significantly by about a third, whereas neither the baseline levels measured years earlier, nor the genetic suggestions of differences in 25D, neither of those were predictive. So supplementation, good idea. However, the report from America, from Hollick's labs, is even more impressive. There were over 190,000 full data sets across all 50 American states, with 25D measured over a short time span shortly before the pandemic hit them. If you look, therefore, at the subsequent rates of COVID positivity, shown here, against D status measured just pre-pandemic, you will see a consistent fall in the risk with higher status. That's 20 nanogram, 50 nanomolar, up to about 140, 50 nanomolar. That's the normal range, if you like. However, even more impressive is the division of the data by latitude here. I can't see the labeling, I hope you can. Here you have northern states, they have a higher rate, but it still falls with better status than do southern states, so that also falls, but not as strikingly. Then if you look by ethnicity, the white Americans had the lowest risk and the lesser effect of improved D status. Remember, this level being regarded as replete in many countries, so perhaps that's not surprising. But if you looked at the African Black Americans, they had a much higher risk rate and a better fall with higher levels, whereas Hispanics with their brownish skin were in between. So how should you prevent deficiency, in particular in people with dark skin in Britain? Well, those who know about it and can afford it will buy over-the-counter supplements, and everyone I know is taking it. But the British advice is the daily amount you should take is 400 units a day, although they have upped it to all year round, but this is not enabled. Compare this to NICE advice, that's our National Institute for Clinical Excellence, that advises on treatment. Treat deficiency, less than 25 nanomole per litre, using, this is what is in their publications, recent, Fixed loading doses up to 300,000 units daily or weekly, followed by lifelong maintenance at 800 units. Our 40 to 60% of deficient Britons could do with being told to take that years ago. Or you can treat them with 20,000 units once a week for 7 weeks, or 4,000 units daily for 10 weeks. Now just look at the totals. If you were taking our recommended daily intake, to get to the 7-week total would take you about a year, and to get to the 10 weeks at 4,000 units would take roughly 2 years. So it's not going to correct adult deficiency. We need a long-term solution, and food fortification is leading the way. In Finland, they've done the job. They started nearly 20 years ago, doubled the amount they added 10 years ago because it wasn't quite right, provided supplements for high-risk groups, and 10 years ago they'd done it, apart from recent immigrant groups. What did Britain do in that time? We had one statutory fortification running, and that was of margarine and fatty spreads, and we abolished that requirement in 2013. Very recently, flour fortification, together with free supplementation of high-risk groups, has been suggested as a cost-effective solution to deficiency for Britain. That was suggested a year or more ago, I think. But that committee is still looking into it, and I haven't heard that there's an outcome. This would prevent deficiency, abolish this horrible long-standing gap in public health advice, let alone provision. It should improve musculoskeletal health lifelong, preventing rickets, infantile hypocalcemic illness and death, and osteomalacia. And interestingly, it has now been shown in the VITAL trial, it would also reduce cancer mortality rates, imagine, by 17% overall. Oh Lord, my computer's about to switch off, that's interesting. But it's double the rate of non-obese people. Remember, we showed they need to give more, but of course in the trial they didn't give more. It would reduce mortality rates, it would reduce fracture risks. Vitamin D skeptics agree, but at much higher levels than we regard as normal. It would contribute to reducing the dangers of future viral pandemics and abolish a racial disparity in public health provision that can be regarded, and I'm afraid I do regard, as discriminatory. So I think it might only be a small contributory factor to avoid vitamin D deficiency, but general health would make it sensible, and the COVID epidemic surely makes it worthwhile. It's cheap, it's safe, and it could help. What's not to like? Thank you.